Hello and welcome to today's webinar. My name is Trevor. I'm the Communications Manager for the Canadian Cancer Survivor Network. Thank you everyone for attending today's webinar, the latest in the fall leg of our 2025 webinar season. If you're new to our webinar, a little background on our group. CCSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in discussion and to act on evidence-based best practices to alleviate the medical, emotional, financial, and social costs of cancer. For more information, visit survivornet.ca. This webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. We will add a quick Q&A session at the end, but if you would like, please put your questions ahead of time in the chat at the side here, should be at the bottom right of your screen. Now, this webinar was made possible by grants from AstraZeneca, Astellas, EMD Sereno, Sanofi, Boehringer Ingelheim, AbbVie, Amgen, Eisai, Bristol Myers Squibb, Janssen, and Merck. Is because of their continued support that we can host the CCSN webinar series, and thank them for their commitment to our educational endeavors. And now I would like to introduce our presenter, Dr. Stephen Lamb. He is a professor of medicine at the University of British Columbia in Vancouver, Canada, a distinguished scientist, the Leon Judah Blackmore Chair in Lung Cancer Research, and MDS-Rix Endowed Director of Transition Lung Cancer Research at the BC Cancer Research Institute. He is the medical director of the Lung Cancer Screening Program in British Columbia. He is a recipient of the IASLC Joseph Cullen Award for lifetime scientific achievements in prevention research of thoracic malignancies, and the Doctors of BC Terry Fox Medal and the King Charles Coronation Medal. And so without further ado, I'd like to turn it over to Dr. Lamb for his talk, an update on lung cancer screening.
Good morning or good afternoon. Yes, thank you, Trevor. So I'm Stephen Lam. I'm just going to give you an update on where we are in lung cancer screening worldwide and also in Canada. So these are the things I would like to discuss. What are the lung cancer risk factors? What are the eligibility criteria for lung cancer screening? The risk and benefits of lung cancer screening, and how we can integrate smoking cessation into a screening program, and a brief overview of the process of lung cancer diagnosis for screen-detected lung cancer. So there are a number of studies that show that lung cancer screening using low-dose CT can reduce lung cancer mortality. So this is a Cochrane database analysis of all the randomized trials that have been reported worldwide. So overall, low-dose CT screening can reduce lung cancer mortality by over 20% compared to no screening or screening with chest X-ray. So based on these results, many countries or regions around the world, including Canada, have screening programs or implementation studies. So Canada is one of 14 countries that have organized national or regional screening programs. This is highlighted in the green color. And then we have 8 other countries that have formal commitment to implement low-dose CT screening, shown by the blue. And there are also over a dozen countries or regions in the process of doing pilot study or implementation studies.
I apologize, Dr. Lamb, for the interruption, but it doesn't seem that we can see you flipping through your slides. It still is on the first slide in our view. If you could please just reshare your screen, please, and thank you.
Yeah. Can you see my screen now? Maybe I just try to move the slides again. Can you see the screen moving?
Yes, now we can see the movement of the slides. Thank you. It's currently on the overview tab.
Maybe I'll keep it on this mode. I think the other mode seems to have problem.
Yes, absolutely.
Yeah.
Right. Thank you very much.
Yeah. So just to recap what I just said, based on solid evidence that low-dose CT screening can reduce lung cancer mortality, many countries or regions around the world have screening programs or in the process of implementing one. So Canada is one of the 14 countries that have organized national or regional lung cancer screening program, shown by the green. And then the 8 other countries have formal commitment to implement low-dose CT screening, shown by the blue. So Australia is actually the latest country. They have a national screening program. They just started screening as of July of this year. So where are we in terms of lung cancer screening in Canada? So I show in the green the provinces they have organized a program or have a firm commitment to start in the next few months. So this includes British Columbia, Ontario, and some of the Atlantic provinces. And then there are other provinces like Quebec and have a phase program. And Manitoba is in advanced phase of planning, just waiting essentially for government approval to move forward. So what are some of the risk factors for lung cancer? So we know that age is a very important parameter. It's unusual to see patients with lung cancer below the age of 50. But you can see in both male and female. So a male is shown by the blue curve here and female by the pink curve here. You can see the peak incidence of lung cancer is in age 74 or so, and then gradually decline. But actually, this peak is quite broad, extending maybe to 80-year-old. So we know that age is a very important risk factor. Now, we know that smoking is the most important cause of lung cancer. So this shows you the accumulated risk of lung cancer versus age. So we can see if someone continues to smoke, that the risk will keep on going up as we age. But unfortunately, after smoking for a long time, when we stop smoking, the risk does not disappear completely. So for example, if we stop smoking at the age of 60, the risk is not the same as someone who continues to smoke, but is still substantial. This is the reason why in screening program, we screen people who have stopped smoking. And this is confirmed by the international lung screening trial that we have conducted in Canada, along with people in Australia, Hong Kong, and Spain. When we look at the study, with people who have taken part in our screening trial, 12% of people have stopped smoking for 15 years or more. So in the US, the cutoff point for screening is 15 years of quitting smoking. So we have shown that this is actually not a good thing to do, because they will miss 12% of people who actually have lung cancer. And then the 4.8 12% of people actually quit smoking in this with this smoking cessation criteria, and almost 5% of them will have lung cancer. And the majority, 88%, are stage 1 or 2 lung cancer. So what are some of the risk factors for lung cancer? So we all know that smoking globally is the most important cause, but you can see some countries, for example, in Central Asia, certain parts of Latin America, and also in South Asia, actually outdoor air pollution exposure is the most important cause of lung cancer. Another thing is the household exposure to pollution indoors, usually to fossil fuels. We can see this is particularly a problem in Africa, in Eastern and Western Africa, and also Central Africa, and also in countries at a lower socioeconomic level. So we have to realize there are many other factors for lung cancer that explain the reason why people who have never smoked get lung cancer. If you look down the list, we always talk about secondhand smoke. This is actually the 5th most common cause of the risk factor for lung cancer worldwide. And radon, there are lots of attention or interest in terms of residential radon exposure. This is actually number 6 on the risk. We have to realize that radon exposure is very regional. And also, even if we live in a region with high background radon, it doesn't mean the risk is always high. It depends on how our house is being constructed to allow radon to be trapped indoors or not. But if you look at the whole list, the majority of these causes are actually occupational exposure to asbestos and other minerals that we can see. So we need to consider exposure to other factors in terms of lung cancer development. So this is the age standardized incidence rate of lung adenocarcinoma that we can attribute to ambient particulate matter pollution worldwide in 2022. The World Health Organization recommends the PM2.5 level to be 5 microgram per cubic meter or less, but you can see 95% of the world population actually exceeded this limit. And then you see the darker red color of the highest pollution exposure countries. This is particularly the case in Asia and certain parts of Africa, and more so in terms of women being affected by air pollution exposure. So this is a recent study that we did in collaboration with a group in Taiwan, where they have conducted a screening study in people who have never smoked, the so-called talent study. It's a large study involving almost 10,000 people who have never smoked. So what we found is using their residential address at the time of enrollment into the screening program, there was a significant association between exposure to particulate matter PM2.5 and lung cancer risk. And then we can use different parameters, whether high-risk lung nodules, all cancers, including pre-invasive cancer or invasive lung cancer alone. We can see the risk go up as the exposure level increases. And so this is significant relationship with exposure and lung cancer. And other risk factor we found is also increasing age, female sex, and a family history of lung cancer. They are also associated with a higher lung cancer risk. So forest fires, as we know in Canada in the last few years, have changed the landscape. We have lots of fires across Canada, from Ontario, Quebec, and we have lots of fires in BC and Alberta as well. And these fires they just don't affect people locally, because the smoke gets blown across, depending on whether the wind direction, and can flow to different provinces or even across the border as well. So that result in very high exposure to particulate matter during those few months of forest fires. So this is a Canadian study looking at the effect of long-term exposure to wildfires and cancer incidents. So you can see it depends on how close we live in terms of radius to forest fires, 20 kilometer or 50 kilometer, whether we exposed in the last 3 years, 5 years, or 10 years. So you can see that there is a significant correlation with lung cancer incidence and exposure to the forest fires, even living 50-kilometer radius away from where the fires are. So in addition to outdoor air pollution exposure, we need to consider household air pollution exposure. This is mainly from using solid fuel for cooking and heating. So this is the burden on lung cancer death related to indoor exposure to solid fuel. So again, the darker red color represent the highest burden. This is, you can see in the Eastern, Western, and Central Africa, many parts in Asia, and certain parts in Central America and South America as well. So this is something that we need to consider as well. So I just want to look at some of the contribution of indoor air pollution exposure and lung cancer risk. We have to look at the fuel sources for cooking and heating. So the worst fuels are the ones that we burn coal, that we do not use in Canada anymore. But then there are other countries that use anything from waste to animal dungs, to any wood or wood chips they can find, and in addition to burning coal and charcoal and so on. And this is especially worse if you live in a very enclosed space, and you're exposed to a lot of smoke for heating and cooking. As the economic development improves, people move to cleaner energy. For example, the use of propane gas, and then to natural gas, and then finally the cleanest fuel is to use electricity. So this is almost like what we call an energy ladder. With the poor countries, they use the dirtiest fuel for cooking and heating, like wood and charcoal and so on, animal dung and waste. And then as we have a better financial means, then we move to gas like propane or natural gas, and finally to use the electricity. The way we cook food is also important. There's different ways of cooking. Deep frying, pan frying, or stir frying. And I didn't show here is a barbecue food, so this can be a problem for professional cooks. The worst type of cooking is deep frying, because we heat the oil, and I'll show the reason why it is bad. We generate a lot of fumes, and especially with deep frying, followed by pan frying and stir frying. And this is especially the case if we do the cooking in an unventilated or poorly ventilated space. So there are different types of cooking oils that we use. So for, like animal oil, like lard, we can use different kinds of plant oil from soybean, peanut, sunflower, coconut, avocado, and olive oil. Now, contrary to what we believe, we all know that using polyunsaturated oil, such as olive oil or avocado oil, is better for health, especially for cardiovascular health. This is not the case when we heat the oil up to a high temperature for cooking. So if we heat polyunsaturated oil for cooking, they actually generate more carcinogenic chemicals that can cause lung cancer. While the lowest risk is actually the saturated fat with lard. So it doesn't mean that we promote the use of animal oil. It's just that these other plant oil, they are not designed for cooking at high temperature. Especially in restaurants, people burn the oil until they generate fumes before they put the food in for cooking. And those fumes actually contain carcinogenic chemicals. So ventilation is a very important factor. As you can see here on the left-hand side, if we cook in a very large space, like in a restaurant that is very well ventilated and with a good fume extractor, you can see the smoke just go up to the ceiling, and the cook on the side, they actually don't get exposed much to the fume. But this is not the case in poorer countries where they cook in a very enclosed space and they sleep in the same space, and you can see that they can be exposed to a large amount of these carcinogenic chemicals. So what is the clinical implication of exposure to particulate matter? If you look at people with lung cancer following their diagnosis of early stage lung cancer, if they live in a very polluted area, what we call high PM2.5 exposure, over 16 microgram per cubic meter, their survival is actually half or less than half of those who live in a clean area. So people live in a clean area, they have a survival benefit after diagnosis and treatment of lung cancer. And other studies looking at the survival of people with stage 1 to stage 3 resected lung cancer following the hospital discharge. If they go home and exposed to wildfire smoke compared to unexposed patients, if they exposed within 6 months after discharge from hospital, their survival is worse compared to those who are not exposed to wildfire smoke, and hazard ratio, their risk is actually almost 1.4 times worse. And then during high exposure times, we know that there is increase in cardiopulmonary events like heart attacks and stroke, and exacerbation of COPD or asthma, and especially for those who are receiving chemotherapy or radiation treatment. So essentially, we get exposed to lots of forest fire smoke or outside air pollutants. It's just like smoking and having chemotherapy or radiation treatment. Our outcome will be significantly worse. So you may wonder why this is the case. This is a recent study from the UK that showed even short-term exposure to high levels of particulate matter actually can promote lung cancer. So high levels of PM2.5 kind of turn on the lung cancer proliferation and metastatic pathway. Then people actually can develop lung cancer even with short-term exposure to high levels of PM2.5. And one can also show that in the laboratory in animals and also in cell culture experiment. So probably exposure to outdoor air pollutants or indoor fossil fuel have two types of effect. The first is a longer term effect, where this exposure will damage our DNA and cause lung cancer mutation and other changes that result in cancer later on. And then there's also a cancer promotion effect when you have existing mutated clones in the body. Exposure to high levels of PM2.5 actually can promote the development of lung cancer within a short time. So I'm just going to show you some of the things that we do, how we can have a practical measurement of how much exposure that we have in the past. So what we've been doing in our study is to collect residential exposure from essentially from birth, and then we use satellite data to map the residential address to exposure to PM2.5 and other matters. So just to illustrate to you how we do that. So very often you ask people, well, where did you live 20 years ago or 30 years ago? We may not forget where we live, but we can use a Google Map approach to ask them, what is the landmark that you remember where you live during that period of time? We can drop a pin into that area and automatically generate a geocode to link to the exposure. So I just want to show you how we do that. This example is someone that live in Canada, for example, and then we move to different places. And the first, you can see the person moved to UK, to London, so from Vancouver, and then now moved to UK, and they lived there for a while. And so essentially, we looked at annual exposure, and then how many years they live in that address, and then we sum up all the exposure. And then he moved to Hong Kong. So you can see he forgot where he lived, but you can he remember a landmark there, so you can drop the pin and allow us to have the exact coding near to where the person lives. And then we can generate the exposure level from 1995 until diagnosis of cancer, for example. So we have accurate satellite and ground measurements since 1995, so we can at least trace back the exposure back for about 20-25 years or more. So I think I will go back here. Now, how do we select people who would benefit most from screening? So we have to remember, lung cancer screening, we do not screen everyone above a certain age group, similar to breast mammography screening or colorectal cancer screening. We only screen people if sufficient risk that would outweigh the potential downside of screening. So this is just a study done by Martin Temamagi in Ontario using a large data set in the US called the PLCO trial, where you look at the lung cancer mortality. You generate a model to look at changes in lung cancer mortality, and then whether someone would benefit from screening with low-dose CT compared to chest X-ray in the National Lung Screening Trial. So this is the level of risk. This is lung cancer mortality. So the red curve is the ones that are screened with low-dose CT, and the dotted line is the one that is screened with chest X-ray. So we can see above a 6-year lung cancer risk over 1.5%, we can demonstrate a consistent reduction in lung cancer mortality with screening. On the other hand, as we move to the left side with lower and lower risk, with a lung cancer risk 0.6% or lower, one cannot demonstrate the mortality reduction benefit. So this is the reason why we have to draw a line in terms of the lung cancer risk threshold to select people who would benefit from screening. So these are the two main ways of selecting people for screening. In the US and in Europe, from the Nelson study and in the initial Canadian Task Force recommendation 2016, which no province in Canada use, we use what we call risk factor approach, essentially age and smoking, and how long they have stopped smoking as enrollment criteria. We all use the PLCO model that was developed by Martin Temamagi. So in addition to age and smoking factor, we use 6 other parameters to determine lung cancer risk. So, for example, we use educational level, which is a proxy for socioeconomic status. So, in general, people with less than high school education at a higher risk for lung cancer. People with a family history of lung cancer, this is immediate family, blood relatives like parents, brothers, sisters, and children. The body mass index based on weight and height. So, surprisingly, the lower the body mass index, the higher the lung cancer risk. COPD, or chronic obstructive pulmonary disease, is also a significant lung cancer risk factor. Another thing is a personal history of cancer. So, for example, someone has skin cancer, cervical cancer, or bladder cancer, they also a higher risk of lung cancer as well. What we also found is race and ethnicity is also an important risk factor. So, for example, Indigenous people and Black Canadian, they can get lung cancer at a younger age and smoking a less amount of tobacco. So we need to take into account the race and ethnicity effect as well. So at the present time in Canada, we screen people between the age 55 to 74. I think some province may drop the age down to 50 to 74. And we include people that smoke in the past or currently smoking. So we do not use the 15 years of smoking cessation as a cutoff. We all use the PLCO the model. Some provinces in Canada use, like in BC, we use the race model that they take into account ethnicity, but Ontario use a no race model. So it depends on what we would like to achieve, and also the threshold. In Ontario, the cutoff point is 2% lung cancer risk over 6 years, while in BC, we use a 1.51% threshold. So this is all based on health economic and CT screening capacity consideration. If we use a lower threshold, then we have to screen more people, we find more lung cancer, but we have to have more resources to do the screening. If we use a higher cut point, we screen fewer people, the proportion, the percent of lung cancer found will be a little bit higher, but the total number of cancer found is actually lower because the population base we are screening will be smaller. So people always say that why don't we screen people above 74 years of age? If we look at the lung cancer incidence and mortality, in terms of number of incidents, it actually peaked around 74, but it's still a substantial number that develop lung cancer at higher age group. But in reality, if we stop at 74, if people have little nodule or spot in their CT scan, we usually continue for screening for at least 2 more years. So essentially, we're screening people until the age of 76. But the other consideration that we need to have in screening older people. If you look at the life years gain, it's actually will be smaller, because suppose our average life expectancy is 85, for example. If you screen people at the age of 80, the mileage we gain, even if they found the lung cancer, would be lower, while we spend the same amount of screening the person. And also older people tend to have more comorbidity, like heart disease or other diseases, and higher risk of competing causes of death, not from lung cancer. And in terms of treatment like surgery, the adverse event from treatment may also be higher. Now, it doesn't mean that people won't benefit when they're older. They're very healthy 80-year-old who may benefit, that they're unhealthy 50-year-old who would not benefit. So this is the reason why we really something we need to examine as to how do we determine fitness for screening. So this is just a study to look at the different models to find people for lung cancer screening using the risk factor like the US Task Force criteria. The sensitivity to find people with lung cancer is actually much lower using the US Task Force criteria. Only 43% of people with lung cancer are suitable for screening using the age and PEG years criteria. While using the PLCO criteria that we have in Canada, 3/4 of people with lung cancer would be eligible for screening. We also decrease the disparity from race and sex disparity using the risk model versus the risk factor approach to screening. So another advantage of using the risk model for determining screening eligibility is cost effectiveness. Just don't want to burden you with how these things are done. I'm not a health economist either. So essentially, this is the amount of money that we gain from screening and versus the amount of money that we have to spend in terms of finding cancer from screening. So this dotted line is the willingness to pay level. So by and large, the costs that are above this line are usually fundable by healthcare system. The 50,000 per quality life years gain, the pay line. This is a solid line, is 100,000 pay line. So below this solid line, very few healthcare system will fund those health services. So in between these two lines, it all depends on how much money people want to spend. Some may still want to go ahead with the health service. So this is to show you the advantage of using the PLCO risk prediction model. So for example, in BC and Ontario, we are operating at this line well within the cost-effective range. If you look at the US Task Force, they're actually below this line as they dropped the kind of recommendation from 55 to 50 years, and then 30 PEG years to 20 PEG years. They actually become more cost ineffective, less cost effective. So these are some of the things we need to consider: is how much money we spend and how much gain we have for the money that we use. So it's an important question. They always get asked who should we not screen. So screening is not for everyone. So for example, someone that's already diagnosed with lung cancer, they are beyond risk. They need to have clinical follow-ups as appropriate. And people with major comorbidity, so like someone with severe COPD, they're already in the home oxygen, they cannot climb 2 flights of stairs. they really cannot would not benefit from screening. And people with severe heart failure, renal failure on dialysis, or bladder cancer on active treatment or follow-up, they shouldn't be screened. Unfortunately, this is not black and white, as we all know. When people call into the screening program, we ask them, can you climb 2 flights of stairs? They say, oh yes, I can do that. But in actual fact, they are hanging onto the rail and walking upstairs, and they think they will they just want to be screened and meet the screening criteria. So that's why we try to develop better means to advise people whether they would or will not benefit from screening. And also, screening is not for people who already have symptoms suspicious for lung cancer. So for example, a cough that does not go away or getting worse. So usually for a cold, the cough will disappear within 2 to 4 weeks. So it doesn't linger on for more than a month. Or someone coughing up blood for some unexplained shortness of breath, they should get a chest X-ray or CT scan for lung cancer diagnosis instead of coming for lung cancer screening. One thing we often get asked is the downside of screening. So there are essentially 3 potential downside of screening. One is a false positive rate, so finding some abnormality of the CT scan that need further follow-up or investigation, and then overdiagnosis and radiation exposure. So I'll explain what those things mean. So on the CT scan, because it's such a sensitive means of detecting abnormality, we often see spots, what we call spots or nodules on the scan. The majority of them are not cancerous. They can due to scars, they can due to inflammation or infection. Only a small proportion are related to, are actually malignant. So this is the reason why we need to have a very good nodule management system to decide who should have a repeat screening before the annual or biannual repeat screening, who should be referred for a diagnostic workup. So from the baseline screen, in general, about 13% of people would be found to have some spot in the lung. They're usually a low risk. They need to have a repeat CT scan in 3 to 6 months. There are about 2 to 3% of people with more suspicious nodule that will be referred for a diagnostic workup. But of those, only about half of them actually need a biopsy. So we can see the chance of getting a biopsy for the non-malignant cause is actually quite small. And then on subsequent screening, because now we have a baseline scan for comparison, we know whether the spot or nodule is new or old, allow us to be more accurate in deciding whether we need to do something more. So that's the reason why in subsequent screening, the false positive rate is actually significantly lower. So overall, the false positive rate is very similar to other screening program. So overdiagnosis is finding a cancer that would not cause the patient symptoms or death in his or her lifetime. But in actual fact, overdiagnosis from long-term follow-up is actually quite small. It's around 3 to 9%, around very similar to mammography screening, about 10%. Radiation exposure is always a concern, but we are doing what we call a low-dose CT. A low-dose CT had 20% or less the regular the radiation dose compared to a clinical scan. So it is about 3 to 6 months of environmental exposure to radiation. So if someone have an annual screen, a CT scan for 10 years, essentially the radiation exposure is about 1/3 of what one would get from background radiation during the same period of time. So this is the reason why we try to cut down the interval of repeat screening. So right now, a lot of provinces are still doing annual screening. In British Columbia, we're the only province that have a biannual screening provision. The lower risk people actually have a scan every 2 years rather than every year. So as I said, false positive rate is all related to the nodule management protocol and the screening frequency. So that's something that we always need to address in terms of quality improvement. Overdiagnosis is thrown around quite a bit when people talk about the downside of screening. It's actually an epidemiological concept. When we do a biopsy and find cancer, the pathologist cannot tell you whether the cancer has an indolent growth trajectory or something that's very aggressive that will cause someone to die within a short time. So this is something that we can see on long-term follow-up as to how much overdiagnosis we have due to the fact that people do die from competing causes of death, like from a heart attack or stroke or other cancers, that kind of thing. So I just want to turn to how do we address who and where we should direct the screening. So this is just give you an example in British Columbia. How do we address inequity in terms of spatial access to lung cancer screening service? We know from other study of health service delivery, the longer the patient has to travel, the less likely the person will access that health service. So what we did is on your left side, we looked at where the lung cancers are found in the province. So you see BC, just like Ontario or Quebec, have a large surface area. But we can see the lung cancer actually concentrated in certain pockets in large urban areas that's shown by the purple. So we decide where the lung cancer patients are found. And then we determine the travel time. So we look at in British Columbia, we have 36 screening sites spreading out throughout the province. So we look at what's the travel time to each of the screening center. So what we found is, on the average, 70% of lung cancer patients can access a CT screening site within 20 minutes of driving, and over about 90 to 92% can access a screening center within 1 hour of driving. So that means only about 8% of people have to drive more than an hour to access screening. Now, obviously, unfortunately, these are people living in a rural area who have poor access to a hospital or clinic in a larger city center. So something we need to look into, how we can deliver the services to some of these underserved people. So this is just an example how a centralized screening program in Canada works. So in Canada, we all provincially or territorial funded healthcare delivery system. So screening programs are run by cancer agencies. This allows us to have a standardized policy and procedure for delivering the care, and make sure we have consistency and timely collection of data and reporting. So, for example, in British Columbia, a patient can contact the screening center by telephone himself or herself, or the primary care provider can refer the patient to us by a fax referral if they think the patient would not call, or some language or cultural issue they would not call the program. So when they contact the program, we have trained navigators to talk to them to determine whether they are eligible for screening. If they're still smoking, we provide smoking cessation counseling to help them to stop smoking. And then if they're eligible for screening, we automatically schedule them for a CT scan in one of the sites that is closest to where they live. Now we do need to have a primary care provider attached to them. The reason is if we have what we call incidental finding, like if we find a coronary artery calcification that need to have coronary risk reduction, we need to have a physician or nurse practitioner to provide the care. So that's why we need to have an attached provider. In our experience, about 10% of people may not have primary care provider in this age group. and we try to attach them to a clinic or to a primary care provider closer to where they live. So then they get the CT scan, and they will be reported by a qualified CT radiology reader, and who will report the results. The results are also sent to centralized screening data center called Cascade, that we can generate a report to the patient and also to the referring physician. And if someone needs to have an early recall CT, we automatically generate a referral to organize a repeat CT scan in 3 months. If someone has a suspicious nodule for cancer, we generate a fast-track referral to see one of our diagnostic workup team to be seen within 2 weeks. So I just want to spend some time in terms of how we integrate smoking cessation to lung screening. In Canada, in many parts of Canada, the smoking rate in the general population is around 10 to 12%. But somehow for lung cancer screening, we attract people who are still smoking into the screening program. So in the experience of both BC and Ontario, about 50% of people who take part in lung cancer screening are still smoking. So that's why it's so important that we provide smoking cessation service to them. Because many studies have shown that if we stop smoking and do screening at the same time, we can double the mortality reduction benefit of screening. Even after they stop smoking, after enrollment into the screening program, there's also a benefit in terms of reducing the all-cause mortality by 35%. In terms of smoking cessation success rate, usually with counseling in this age group, they have tried almost everything to quit smoking. The success rate is about 10%. That's why it's so important to have a primary care provider to provide pharmacotherapy like nicotine replacement or varenicline for smoking cessation, because we know that combining pharmacotherapy with counseling can increase the quit rate by almost 2 times. So this is a second reason why it's important to have a primary care provider attached to the screening program. So we also have to remember people who stop smoking is still a substitute for lung cancer. Nowadays, over 50% of people with lung cancer have stopped smoking, and many of them have stopped smoking for 10 or more years. So that's why screening actually is the best option for them to reduce the risk of dying from lung cancer. So this is how the lung screening program can support smoking cessation. So when the person contact the screening program, our trained navigators will go through the smoking cessation questionnaire to them to find out whether they make attempts to stop smoking before, what was successful, what didn't work out, and try to work out a plan together with the patient to come up with another attempt to stop smoking. And also, we also let them know that nicotine replacement is free, at least in BC and a number of other provinces for at least a few months. And some provinces also provide free other smoking cessation drugs like varenicline as well. We also explain to them the benefit of quitting smoking. We have educational material or videos to help them to stop smoking. And many provinces also have Quit Now program that we can refer a patient for counseling as well. So these are the services we try to have to provide for them. So in our experience, actually, smoking cessation rate can be between the 10 to 20% range, especially with pharmacotherapy. The cessation rate can be in the 20% range. So these are some of the resources that many screening programs have developed to explain to potential participants what is lung screening is all about, what are the benefits and downsides of screening, and patient stories, and so on. So just to, we have a video, for example, walk the patient through what the screening CT is all about, so they know what to expect when they step into the CT department. And I'm just going to show you a video, and when they get the result, what the result mean.
After attending your lung screening appointment, a radiologist such as myself will look for spots, also known as nodules, on your scan. Now, these spots indicate small lumps of tissue that many people have. Your scan alone cannot tell me whether these spots are scars, areas of inflammation, or cancer in your lungs, and so when spots are found, further investigation is usually required. Your next steps are determined by the size and appearance of any spots found during your lung screening and other details I notice on your scan. You may receive one of the following 5 possible results based on your scan. The first result type is no concerning findings. This means I did not notice anything of concern from your scan. You will receive a reminder letter when it's time to screen again in 2 years. Screening works best when you receive regular lung scans to see if there are any spots or changes to existing spots since your last scan. Even if there are no spots now, you may get them in the future as the risk of developing cancer increases as you age. That's why it's important to return for lung screening when you're due. The next type of result is low chance of cancer. This means you are considered to have a low chance of lung cancer. You will receive a reminder letter when it's time to screen again in 1 year. Remember, screening works best when you receive regular lung scans, as we would like to keep an eye on the health of your lungs. This means returning for lung screening when you're due. The next result type is additional screening required. This means I noticed something in your scan that may be related to inflammation, infection, or a need to monitor an area more closely. I would like to check again in 3 months to see if there are any changes. You will be contacted to arrange a follow-up scan in 3 months. The next type of result is follow-up required. This means your lung scan has revealed some spots that require further investigation. This does not mean that you have cancer, but it's important that you attend all follow-up. You will be contacted shortly by a chest specialist to arrange for follow-up, which may include more scans or a biopsy. A biopsy is when a small sample of tissue is removed from your lungs so it can be looked at more closely. It's possible to receive a result called findings not related to lung cancer. In addition to your lungs, your scan may show abnormalities in surrounding areas, such as your heart. If anything unusual is your scan will be sent to your primary care provider, who will contact you for follow-up. If you currently smoke, one of the best things you can do for your health is to quit smoking. I know quitting isn't easy. However, quitting smoking doubles the benefits of lung screening and significantly improves your health. There are many resources to help support your decision to quit. For more about these resources or about your lung screening result, talk to your primary care provider or visit www.screeningbc.ca/lung.
So this is just some of the education material that we produce. So we always welcome the public input like yourself to improve on some of this educational material or develop new ones. So I've just gone over some of this category that we use when we send a letter to the participant. So we try not to cause alarm or psychological stress from people using words like cancer. So I think we, especially for the lower risk groups. So I just want to say briefly about the use of artificial intelligence in lung cancer screening. In British Columbia, we use artificial intelligence to aid the radiologists in reporting. So when we talk about artificial intelligence, there are different phases of development. The first thing is the initial stage. The radiologists look at the nodule, they can point to the nodule and then do some measurements that way. And then in the second phase, the computer can automatically measure and track the nodules. And the third phase, we can actually generate a lung cancer risk score. And the final phase is we can fully automate the whole system that can read the CT scan and generate a report. So we are around this phase now that we can automatically detect abnormality in the CT scan and do the measurements and generate the risk score, and the radiologist can accept or delete the changes if they think the nodule is not a real nodule, for example. They can occur in a few percent of the time. So this actually speed up and improve the accuracy of reporting by the radiologist. So just to spend a few minutes as to how we diagnose lung cancer. So diagnosing early lung cancer actually is quite different, and then someone presented to the hospital or physician with a mass and symptoms. These are tiny little shadows or spots, maybe 2 centimeters or less. They are actually very challenging and requires special expertise and equipment to diagnose. So, for example, we need a smaller bronchoscope to access smaller airways. We need ultrasound equipment to confirm where the nodule is, and we need some kind of CT scan or fluoroscopy to confirm before we do a And then we now have a navigate where we can use a CT scan to generate a virtual map to tell us where the nodule path is. And then we can synchronize the real-life bronchoscopy image with the virtual image. So essentially, we look inside, we can follow this blue line to tell us we should turn left, right, and so on until we reach the target to take a biopsy. And the most recent development is a robotic bronchoscopy that can do this kind of thing a little bit better, but at the same time, robotic bronchoscopy is substantially more expensive than a standard bronchoscopy in terms of disposable supply. We also developed new technology to use fiber optic to see very small lesion to characterize it before we take a biopsy. We will also do some treatment. So in terms of resection, because it's a very small lesion, we do not actually need to remove the whole lung that will sacrifice lung function capacity. So very often the surgeon can do what we call video-assisted thoracoscopic resection or surgery or VATS. Essentially, prior to surgery, the radiologist drop a little wire into where the nodule is, and the surgeon open a little hole using instrument to see where this little wire is, and just remove a small segment of lung to remove the cancer that way. So most of the patients with early lung cancer can have this kind of minimally invasive surgery, and many of them actually go home within 2 or 3 days after surgery and back to work within a month or so. So that's why finding cancer early allows us to have more options for treatment and do it safer as well. And for people with bad lung function, if they cannot have surgery, we can also provide stereotactic radiation treatment with very similar results. So just give you some idea as to what kind of result we get in the screening program. So in BC, we started a province-wide screening program in May of 2022. So to show you the result at the end of last year. Even in a smaller province like British Columbia, compared to Ontario or Quebec, where over 24,000 people contact the program. 73% of them are eligible for screening, and almost 90% get the CT scan. The age is actually not very old. The mean age is only about 65 years. You can see almost half of them have high school education or less. And we're reaching people with lower socioeconomic status. And we also have a good participation by Indigenous people. In the general population, in a similar age group, well, in BC, we have 2% Indigenous people, while in the screening program, with 6% people, Indigenous people taking part in screening. And we have very similar male and female ratio. So this is how screening does. The cancer detection rate is 1.6%, which is very high. In the US, using age and PEC years criteria, the cancer detection rate is actually less than 1%. So with screening shown by the blue line, we essentially do what we call a stage shift. Instead of majority of patients stage 3 and 4 lung cancer, when they're found by clinical symptoms, shown by the red line here, the red bar here, we're screening the majority, over 70%, are stage 1 or 2 lung cancer. They're amenable to surgical and other treatment. So in summary, I think screening have changed the way that we think and manage lung cancer. When people talk about lung cancer, they always think about smoking and death, but I show you lots of people have stopped smoking already, and the majority of patients we are seeing now in the screening program or in the clinical setting have stopped smoking already for a number of years. So that's why screening is so important for them. This is the only option they have to reduce their chance of dying from lung cancer. So I think with screening, we can change the scene to something that is curable. There are many other treatments that is now available for lung cancer, even for advanced cancer, that produce much better quality of life and also improve survival as well. So I think the scene for lung cancer is totally different than what we have 10 or 20 years ago. I think screening will play an increasing important role in the years to come. So I think I'll stop here. If you have any question, I can answer.
Wonderful. Thank you so much, Dr. Lam. And if you have any questions, please put them on the questions tab on the right side of your screen. We do have one so far. If you have a different kind of cancer than what they will be performing a CT scan, what should you ask to include your chest and lungs, or will this increase your risk?
So the screening CT essentially covers something just above the lower neck all the way down to the upper liver. So the screening, the CT have a very low dose exposure, what we call 1.5 millisievert. It's very compared to a regular diagnostic scan, which is around 4 to 8 millisievert. So we can see that the dose is much lower. So we don't do a regular CT to cover all other parts as well, because it's not indicated to expose to your abdomen, for example, to the radiation.
Mm-hmm. Another question that we have, you mentioned a couple of ways that are different from CT scans for diagnosing lung cancer. I was wondering if there was other things that are down the pipeline that are new and upcoming diagnostic therapies that were coming down the pipeline that could make lung cancer a less risky affair to diagnose.
So in Canada, we have active research going on looking at two things. One is using what we call blood markers. So there are proteins in the blood that reflect the development or presence of lung cancer. So we are working on using blood tests to detect lung cancer early, and also when you have a nodule seen on the CT scan to find out whether the nodule is cancerous or not cancerous. We're also working on a breath test. Essentially, you blow the air into a tube, and then we analyze the chemicals that are breathed out in the tube to find out whether someone is harboring a cancer or not. So these are kind of non-invasive tests that we may find useful in the future. They're not yet ready for prime time. There is commercially available tests like a multi-cancer detection test that you can read about in the social media. But I think we have to be careful about these tests. Number one, they're very expensive, and number two, these multi-cancer detection tests are very low sensitivity for early lung cancer. So the sensitivity usually less than 30%. So it can give people the false assurance, oh, I have a negative test, I don't have to worry about cancer. But that's not quite the case. So we still have to work out as to who would benefit from this kind of test, because there are lots of downstream implication, right? Because they give you signal that you can have a cancer in your lung, in your bowel, in your pancreas, and so on. You have to work out what is the diagnostic pathway when you get a positive test, and what's the implication in terms of workup for so-called positive tests that may be false positive. So I think we need to do more research on some of these detection tests.
Because I've been hearing so much about these blood cancer detection tests throughout. It's a very exciting development in cancer care, but when it comes to lung cancer, from what you're saying, there are potentially better alternatives down the pipeline than the blood tests.
Yeah, I think we need to consider the cost, right? A CT scan probably costs $100 or $200 to do. When you have a blood test, it's over $1,000. I mean, just tell us it's not going to be useful, right?
Exactly.
So something had to be very cheap and accurate in order to be useful.
Well, I don't see any more questions right now. So thank you very much, Dr. Lam, for your presentation. Very eye-opening, and it was good to see an updated picture of lung cancer screening, not just in Canada, but also throughout the world. So thank you very much for your presentation.
Yeah, thank you for having me.
Excellent. Now, this webinar was made possible by grants from several organizations, including AstraZeneca, Astellas, EMD Sereno, Sanofi, Boehringer Ingelheim, AbbVie, Amgen, Eisai, Bristol Myers Squibb, Janssen, and Merck. Is because of their continued support that we can host the CCSN webinar series, and thank them for their commitment to our educational endeavors. Now, this is one of a series of webinars that we'll be presenting this fall. The next one is happening next week. So if you'd like to stay in the loop about webinars, visit our website or check your email for our e-blast. If you're not seeing the email in our inbox, check your spam folder, because we do use a third-party email service, and make sure that you are subscribed to our newsletter on our website to not miss a thing about what we're doing here at CCSN. All of our webinars can be found at survivornet.ca/webinar, or you can find them on our YouTube channel. And so with that, thank you very much for listening and watching, and we will see you on the next one. Have a good day.